All right, let's dive right in. We're about to step into one of the most high-pressure situations any surgeon will ever face, the oral board exam. Think of it as a simulated, high-stakes viva scenario focused on chest trauma, where every single answer is critical.
So for this, I'm going to be playing both roles, the tough examiner and the candidate who's on the hot seat. The exam's about to start. Good morning, candidate. Please have a seat. We have a case for you today.
You've been called urgently to the emergency department. The patient is a 37-year-old man who was just in a fight. Paramedics report he has a single stab wound to the chest, specifically the second intercostal space on the left side. He's your patient. Tell me your approach. Okay, so as the host, let me just set the scene for you. This first part is all about that initial approach. You got to remember, in the total chaos of a trauma bay, having a system isn't just a good idea, it's an absolute lifeline. It's what keeps you from making huge mistakes when the pressure is on. So let's see how the candidate handles it. Candidate, the patient is rolling through the doors right now. How do you approach this situation? Now, this right here is a classic opener. It's a high-yield question designed to see if the candidate has their core trauma protocols down cold, right from the very start. Thank you. Well, first things first, I'd make sure the area is safe for me and the entire trauma team. Then I'd immediately launch into the Advanced Trauma Life Support, or ATLS, protocol. That means the primary survey. A for airway, making sure to protect the C-spine. B for breathing. C for circulation. D for disability, or a quick neurocheck. And finally, E for exposure. And during exposure, it's absolutely crucial that we log roll the patient to check their back. You never know if there's another injury hiding back there. And just like that, things take a turn. Any good examiner is going to throw a curveball like this to see how you handle pressure. Your patient isn't getting better. They're getting worse. They're crashing. You've started your primary survey. You've got IVs in, you're pushing fluids and blood. But the patient is not responding. In fact, his condition is deteriorating and it's happening fast. Whew, these numbers, they paint a really grim picture. A blood pressure of 80/40? That's dangerously low. A heart rate of 127? It's just beating like crazy trying to keep up. And a respiratory rate of 28 means he's gasping for air. Put it all together, and these are giant flashing red lights for severe hemorrhagic shock. This patient is bleeding out on the inside, and the clock is ticking. All right, given the location of that wound, right in what we call the cardiac box, and these vital signs, what are the immediate life-threatening injuries that are flashing through your mind right now? And this is exactly where a trauma surgeon's brain has to work at lightning speed. The examiner wants to know if you can instantly think of all the things that could kill this patient in the next 5 minutes, and then how you'd start tackling all of them at once. Okay, given that anatomy, my differential for what could kill him right now includes a few really bad things. A tension pneumothorax, where air gets trapped and collapses the lung and crushes the heart. Cardiac tamponade, where blood fills the sac around the heart and strangles it. A direct injury to the heart muscle itself, a massive hemothorax from a big tear in the lung, or a devastating injury to a great vessel like the aorta or even the main airway. So now that we've identified the potential killers, the very next question is about action. What do you do? This is a huge pivot point in the exam, where you have to go from thinking to doing, from theory to life-saving practice. Excellent. You've got your list of suspects. Now, what is your initial management right now at the bedside? My management has to be both diagnostic and therapeutic, and we have to do them at the same time. I'm going to grab the ultrasound for a fast scan, looking right at the heart to see if there's fluid there, which would scream tamponade. And while I'm doing that, my team is already setting up for an immediate large-bore chest tube. We have to be ready to treat a tension pneumothorax or drain a chest full of blood. You've decided on a chest tube. Tell me, precisely where are you putting it? Now, this is not just some academic question. This is a huge test of your actual procedural knowledge. Getting this wrong isn't just a failed point on an exam. It can cause a catastrophic injury in the real patient. The correct site is what we call the triangle of safety. My landmark is the fifth intercostal space, right between the anterior and mid-axillary lines. And here's the most critical part. The incision goes directly over the top of the sixth rib. You do that to avoid the bundle of nerves, arteries, and veins that runs right along the bottom of every single rib. Okay, we've now reached another major decision point. If the patient is still circling the drain, despite everything we've done, the next move is one of the most dramatic,
Hail Mary procedures in all of medicine. The emergency thoracotomy.
Your patient's pulse is gone. They've arrested right in front of you. What is the specific indication for performing an emergency thoracotomy for cracking their chest right here, right now in the ER? The one primary indication is a witnessed cardiac arrest after a penetrating chest injury. And when we do it, we have 4 main goals. 1, open the sac around the heart to release a cardiac tamponade. 2, get our hands in there to directly control any bleeding from the heart or major vessels. 3, perform internal cardiac massage, which is way more effective than pushing on the chest. And 4, clamp the aorta to redirect what little blood he has left up to his brain and heart. So even if those initial life-saving moves work, the danger is far from over. The Viva now shifts again. The examiner wants to test your ability to handle complications after the procedure and to know the key definitions that will guide what you do next. Let's switch up the scenario. You've put the chest tube in, you get a chest x-ray, and you see the lung still hasn't reinflated, and there's a big, persistent air leak bubbling away in the drain. What's your next move? Okay, a persistent air leak like that tells me there's a pretty significant injury, probably to a major airway, a bronchus, or the lung itself. So my immediate steps are, 1, make sure the patient stays on high-flow oxygen. 2, I'm going to put in a second chest tube to try and get better drainage and help that lung expand. And 3, I'm getting an urgent consult to thoracic surgery. This patient is almost definitely going to need an operation to fix that leak. One final question for you. Your chest tube drains a lot of blood. What is the precise definition of a massive hemothorax? The definition that tells you this patient needs to go to the operating room now. A massive hemothorax actually has 2 definitions, and if you meet either one, it's an absolute indication for surgery. So the first criterion is all about the initial gush of blood you get, an immediate drainage of more than 1,500 milliliters of blood right when you put the chest tube in. And the second criterion, which is just as important, is about the rate of ongoing bleeding. This is defined as continued drainage of more than 200 milliliters of blood per hour for 3 hours in a row. Again, hitting either of these numbers means we're making an urgent trip to the operating room for a thoracotomy to find and stop the bleeding. And that really shows you the complete mindset of a surgeon. You know, the job is never really done. So the immediate crisis is over, but now a whole new set of challenges begins. The question now is, what do you watch for next? And a huge one, a life-threatening complication that's often caused by the massive amounts of fluid we had to give him to save his life, is a severe inflammatory reaction in his lungs called acute respiratory distress syndrome, or ARDS. Constant vigilance is everything. And that wraps up our Viva.